So my name is Dr. Jonathon Kaufman. I'm a general pediatrician and been in practice in the area for about 30 years. And the interesting thing is that although concussions are not necessarily new to us as general pediatricians, there seems to be a much more greater incidence and focus on general pediatricians diagnosing, managing, and treating concussions. Depends on the sports season. Quite a bit in the fall with the contact sports, especially football, and then lacrosse. We'll also see them pretty much year-round. Cheerleading is a big source, and POMs with injuries without helmeted players, gymnastics also. And then we were seeing an increase in just children being children, falling off of a swing, kids roughhousing, playing street baseball or street football without any equipment, or the non-organized kinds of things. Water polo, I had a concussion in water polo a couple weeks ago. Stuff you wouldn't expect to see. Anytime there is a concern about a head injury in their child's either physical or cognitive emotional well-being, they should be evaluated immediately. If they're on a playing field or in a situation where they're playing, they should be removed from that venue immediately and evaluated by somebody. If it's in a sanctioned sport with a school situation, then there should be a trainer available at that time to assess their ability to go back into play or stay out of play. Anytime they're required to go out of play, or again in the parent's estimate that their child is not physically or emotionally or cognitively right, they should call us immediately. The obvious things are if their child gets knocked out or loses consciousness from the event. Obviously that's something that most parents are aware of and will call us right away. The less obvious or more subtle signs of a head injury, brain injury, concussion could be sluggishness of their child, mood swings, headache, nausea, vomiting, vision concerns, sensitivity to light or noise, irritable mood, although it's hard to assess sometimes. And then the much more subtle things that really relate to the following day or the next ensuing few days are cognitive deficits. So short-term memory concerns, forgetfulness, difficulty concentrating on their schoolwork or homework, headaches when they're doing their electronics or screen time or reading, things like that. Well, we'll do a history, and the history is important because we also want to get a sense from the individual or the patient what their memory is or lack thereof of the event, and see if there's any antegrade or retrograde amnesia for the event, which can help us again in terms of diagnosis. And then we'll also do a physical exam for immediate neurological deficits or soft signs that would be certainly very worrisome. And then we tend to do a symptom score of the things I just mentioned, where the child or the patient indicates what they're feeling at that moment, and we can get a score. And then a sort of a mini neurocognitive type of thing, so affect, orientation, some quick things in terms of short-term memory, some sequencing things, short-term recall, things like that. It's a great question. I think, when there's loss of consciousness, we always like to err on the side of caution. That child needs an emergent evaluation, and based on their phone call to us, sometimes we will actually refer them to the emergency room. If there's loss of consciousness on a playing field in a sanctioned sport, most of the time they're going to call an ambulance for safety reasons, and also some liability reasons. The majority of those are not necessarily progressing to emergent situations, but when there's loss of consciousness, sometimes that obviously the impact can be much greater, and there's much more of a need of an emergent evaluation. So it's kind of analogous to anybody else who injures another part of their body. So somebody who's throwing and has an elbow soreness or a shoulder injury, or somebody who hurts their knee, the immediate is rest. And what I tell people is you can't ice the brain, you can't cast the brain. So what we really look for is physical and emotional rest. The controversy now is how long they should rest for. Just like a knee injury or a shoulder or elbow injury, the next step is rehabilitation, which is sort of the new and exciting part about concussion management. So typically they're supposed to have physical rest. And that would include PE, recess, their sport, or any kind of other activity until basically their symptoms resolve. And then emotional and academic rest is the other part, is the tough part. I typically will tell them no electronics, nothing that's taxing to their brain in terms of memory or cognitive insult. And then if they can pretty much manage some light cognitive or academic type of stuff for about 45 minutes to an hour without having resurgent symptoms, they should be able to return to school. Typically is 3 to 5 days, sometimes 7 to 10, but typically about 3 to 5 days. And as long as they're able to go back to school and then the resurgence of symptoms don't recur, then they can stay in that regard. And then when, again, symptoms are totally gone, then we can start return to play. Physical therapy referral can be important for balance, vestibular things, concussion rehabilitation, and that can also speed up that process. Medication management is really controversial other than just pain reliever. There's really been no research that says that medication management such as magnesium for headaches and things like that is shown any short-term or long-term benefits. And then most importantly, on the back end of all this, we really make sure that when they do return to play, there's no second impact, second injury. And if they can't return to play for more than after about 3 weeks, then I usually refer them to a concussion specialist, in addition to, again, continuing physical therapy. We're looking, again, at continued symptoms when they're back in a school setting. We do repeat our neurocognitive assessments in the office, and if there isn't any significant recovery with rest, I'll refer them out to physical therapy and then sometimes the concussion management people. Depending on depending on the injury, the type of injury, their age, and the resolution, we'll see them immediately. We'll see them typically after a few days of injury. And then pretty much what I tell them is, when your symptoms are really subsiding and you feel like you can return to school, then I want to see you back. And then when school's going well, we then will reassess them in the office for return to play protocol. Yeah, so the current thinking is that the neuro checks where you have to lose sleep and wake your child up every 2 hours and stuff like that doesn't really seem to be appropriate or indicated anymore. Being a parent myself, I find that hard to persuade parents not to check on their son or daughter. So I'll usually have them go in and just check, again, make sure they're sleeping comfortably, make sure there hasn't been any vomit in the crib or the bed or whatever it is, and then go back to sleep. Yes. So the only thing I can really tell teenagers, which is really difficult to sell because of the temporal of the brain doesn't mature and everything is today and now, what I want to do today and not 10, 15 years from now is you've got to be true to yourself. And that these things add up. And the easier sell now is this concept of CTE, and in the press that the football players have gotten about how they can become demented and depression and aggressive behaviors. So I kind of ask them, it depends on their sport. So if they're football players, it's a little bit of an easier sell because I can point to a lot of the professional football players that are really struggling or have struggled with it and say that the impact itself is really the issue. And the product of multiple impact injuries in addition to just concussions can really take its toll on your future. And you really need to be true to yourself. And if you are back on a venue and you're returning to play, that this weekend's tournament is really not as important as your long-term future. Baseline testing, I think, is really important. There's a lot of testing things out there. I think you need a good one, but I think baseline testing is important. The problem is that because there are so many different ones out there, there are some inconsistencies. And a lot of the schools will have one that maybe somebody else doesn't. And so what I typically would like to do is, if I know there's contact sport athletes that haven't been pre-tested by their school, as you refer them to a center where they can do a pre-participation testing, and then again refer back to the physical therapy people for post-injury testing to compare the baselines. So the problem with that is that I get a lot of parents who didn't let their child play football when they're younger, and then they really, really want to play. And the problem I tell them with that is that in our culture, in our society, everything when you're younger, when you sign up for a sport or an activity, is designed for participation, skill set acquisition, and fun. And if you don't start playing until you're 11 or 12, then the emphasis unfortunately shifts to competition, winning and losing, and they're not focusing on skill set acquisition. So for example, for football, if you start at 11 or 12, you are not taught how to tackle the right way. That's taught in earlier ages, so that you're really, really losing out, and you may actually increase your risk of injury. Having said that, obviously with the emphasis in our culture on exercise and all of its benefits, the last thing that I would want to do would be tell people not to participate in some type of a sport they enjoy, and if it's contact sport, so be it. We'll go on runs, I'll be honest with you. We always see it in August and September. Then we'll usually get a little bit of a blip, obviously in the spring with lacrosse. And then throughout the year, gymnastics, dance competition, and then you're just average child on the playground who plays pickup games. I would say in our general pediatric office, we probably see, I don't know, I personally see probably 2 to 3 a month.